Hi everyone, we're back for part 2 of chapter 27 for hematology, and we're going to start with thalassemias. So thalassemias are hereditary hypochromic anemias that are seen in the absence or decreased synthesis of the normal hemoglobin peptide, and they can either be alpha or beta globulin chains, and also seen with the excess of other hemoglobin chains. The protein abnormalities result in hemoglobin issues whose names are based on the alteration of the globulin chain. So we have beta thalassemias, alpha thalassemias, etc. So the possibility of a thalassemia can increase if the onset of anemia and symptoms are seen prior to 3 to 6 months, and if there's a family history of anemia, if there's been miscarriage, jaundice, gallstones anemia, or splenomegaly. The first one we're going to talk about is alpha thalassemias, and it's composed of several different hemoglobins that can present in different ways. So thalassemias are categorized by whether they're heterozygous or homozygous. And heterozygous disease is seen with hypochromic and microcytic thalassemias. The homozygous is more hemolytic. With the thalassemias, there is the anemia, but then there's also increased erythropoiesis, and that results in bone marrow expansion. With the marrow expansion, you can see some frontal bossing and hyperplasia of the maxillary bones, which can lead to some facial deformities. Also with the alpha thalassemias, we've talked about the several variant hemoglobins, and based on the number of hemoglobin or gene deletions refers to the severity of the symptoms that are seen with the deletions. So a 3 gene deletion can result in severe, even fatal disease, such as hydrops fatalis, which is a severe anemia that is not compatible with life. 2 gene deletions present as more hypochromic and have low hemoglobin, and the absence of any gene deletions just causes mild anemia and often some erythrocytosis. Homozygous hemoglobin H presents microcytic hyperchromic anemia that often manifest as a hemolytic anemia with hepatosplenomegaly and jaundice, and then you will see some thalassemia-like bone changes. With these kids during time of stress to the body, they may require blood transfusions. There are 2 different types of carrier states for alpha thalassemia. In the alpha thalassemia trait, the child exhibits microcytosis and hypochromia but has a normal percentage of hemoglobin A2 and hemoglobin F. The other trait is then referred to as a silent carrier state, but can have either a silent hematological phenotype or present with microcytic hypochromia and some erythropoiesis. Next, let's talk about beta thalassemia. It's mild hyperchromic and a microcytic anemia. Hemoglobin levels are 2 to 3 points below normal, and the MCV average is about 65. These kids are often symptomatic but need to be monitored for iron accumulation. This disease can often be confused as an iron deficiency or a lead poisoning, but can be differentiated by measuring serum iron and lead levels, the saturation level, and ferritin levels. No treatment is required, but it's important to perform and correctly diagnose so unnecessary administration of iron does not occur. With thalassemia intermedia, your symptoms and lab values may be mild to severe, and in beta thalassemia major, you have more severe findings. Symptoms are present in the first year of life. It's important to have the patient be seen by a pediatric hematologist. They may require transfusions, may require splenectomy. They may need hematopoietic stem cell transplantation, they may require iron chelation therapy, and if untreated, then this bone marrow expansion, as we talked about, can cause some frontal bossing and maxillary overgrowth. The next anemia we're going to talk about is megaloblastic anemia, and it's seen with oval macrocytes and hypersegmented PNM leukocytes. And remember that the PMN is polymorphonuclear leukocytes. So the macrocytes and the PMN leukocytes are seen in the peripheral blood, and then there's megablast known in the bone marrow. It's relatively rare, but this anemia is primarily due to a lack of folic acid, B12, or both. Megaloblastic anemia may develop if the diet lacks these two substances, or if the intrinsic factor necessary for absorption is absent. So if you may see kids that are on powdered cow's milk or goat's milk, a strict vegetarian diet, or may have some tapeworm infestations. Clinically, they may present as being irritable, not having sufficient weight gain, and having chronic diarrhea. They may be weak, be pale, have a beefy red, smooth tongue, and a sore mouth. You will know on labs that they have an elevated MCV, nucleated RBCs, but may have a normal white count and a platelet. So management of these patients is with a pediatric hematologist, and then dietary supplementation to correct the underlying disorder, along with education of the parent and family. Next, we're going to talk about normocytic anemias, and these are where the RBC is normal in size. We see these often with chronic illnesses, possibly with a B12 deficiency, traumatic blood loss, or pregnancy, and it's not very common in children. Other tests that you would do along with your anemia workup, if you were trying to rule this out, is to include lab tests, to be sure and include a BUN and creatinine, liver function test, bilirubin, a SED rate, urinalysis, and thyroid profile. Now let's talk about transient erythroblastopenia of childhood, or TEC. It's a benign disorder that really doesn't have a cause, that occurs in the first few years of life, but usually after the first year. It's characterized by anemia, low reticulocyte count, and erythroid hypoplasia in the bone marrow. The cause of the suppression of the erythropoiesis and the resulting RBC production decrease is not really known, but it often may follow a viral infection. So therefore, viral and immunological mechanisms are suspected to be the cause, even though no virus is seen. On physical exam, you may see the typical signs of anemia with increasing pallor to the skin, low energy, fatigue. There also may be some associated fevers, malaise, lethargy, abdominal pain, upper respiratory infection, and jaundice may occur. The studies that you will order, you may see hemoglobins as low as 2.4. You will definitely note that low retic count, as erythropoiesis is not occurring too aggressively. The MCV and the white count may be normal. Platelets could be normal or elevated. You will see a high serum iron level, and you may see erythroid hypoplasia of the bone marrow if there is a bone marrow biopsy. So the red cells being smaller in size. The differential diagnoses to consider include congenital hypoplastic anemia and a condition called Diamond-Blackfan syndrome, and then iron deficiency. The treatment and the management of it is self-limited disorder and usually resolves in 1 to 2 months. No specific treatment is needed, but if the symptoms and the blood findings are low enough, transfusion may be necessary, and it may require the referral to a hematologist. The next thing we're going to talk about is hemolytic anemia, and that's the premature destruction of red cells. And because they're having the destruction of those cells, in the bone marrow is revved up and produces more reticulocytes. This can be classified as either hereditary or acquired, and it should definitely be considered if you have an elevated reticulocyte count in the absence of bleeding or being on heparin therapy. It is usually seen in infancy and early childhood, and there may be several varieties of it. So it's important to get a careful history so that you can figure out the etiology of it. This includes taking a good family medical history, assessing the child's medical history, diet, medication intake, and environmental exposures. And confirmation of the diagnosis is performed with hemoglobin electrophoresis, the Heinz body stain, and an osmotic fragility test. So let's now talk about sickle cell anemia and traits. It's a complex disorder that is chronic in nature. With it, you see hemolysis, unpredicted complications related to that hemolysis that can be life-threatening but also can cause organ damage. So children that have a homozygous inheritance have sickle cell anemia disease, and that's hemoglobin SS, and it synthesizes hemoglobin S instead of the hemoglobin A. And hemoglobin A carries the amino acid valine instead of the glutamic acid. So since hemoglobin S comes out of solution at a low temperature, low pH, and low osmolality, it can cause collapse of the red cell, which causes sickling and giving that sickled shape. And this in turn causes a chronic hemolytic anemia, and due to the cell shape not being smooth and round and more of a sickle, it can cause pain as the cells are going through the bloodstream. It can cause small blood vessels to clog, causing ischemia and pain, and then there can be vaso-occlusive problems. It is considered an autosomal recessive inherited pattern and is most often seen in African descent, but can also be detected in ethnic groups in the Mediterranean, the Caribbean, and Central and South America, as well as India. So part of newborn screening does include assessing for sickle cell anemia. But if you have a patient that you're concerned maybe having this issue, it's important to do a careful family medical history because many adults don't realize that they're carriers. So some clinical findings and some symptoms that you'll see from sickle cell, as it is a multi-system disease, takes care of the whole body. You're going to see lots of different areas that may be involved. You can see fatigue, anemia, being in a pain crisis, infections, lung or heart injury, ulcers, priapism, splenic sequestration, eye damage, abdominal pain. Children with the sickle cell trait who are heterozygous, so they have a hemoglobin A and a hemoglobin S, positive for the trait, essentially have a benign clinical presentation. Their hemoglobin only contains approximately 30 to 40% of the hemoglobin S, and sickling does not typically occur unless there is some instance of hypoxia, such as being in shock or if they were flying in an unpressurized cabin. However, having the sickle cell trait has been seen as a causative factor for sudden death in young military recruits, college football players, those that are being hyper-stressed, extreme exercise typically that you might see with exhaustion, dehydration, or some form of hypoxia can be major confounding factors towards sickle cell. On physical exam, you're going to see symptoms that emerge in usually the first 6 months of life. It can have vaso-occlusive crises, which can be very painful, splenomegalia. So the splenomegalia may disappear after about 5 years of age due to the body pulling oxygen away from that part of the spleen. You may notice that height and weight slows down after about 7 years, and puberty may be delayed by 3 or 4 years with these patients. Diagnostic studies, you may see hematocrits of anywhere from 20 to 29%, hemoglobin from 6 to 10. The retic count is going to be elevated. You may notice a normal to increased white count or platelets. MCV is usually greater than 80%. And if hemoglobin electrophoresis is performed, you will notice a predominance of hemoglobin S. And differential diagnoses is to include are chronic hemolytic anemia, hemoglobin SC disease, and a combination of hemoglobin S and a thalassemia. With these kids, you will have them in with a pediatric hematologist, and they will be working with you because these kids will definitely need to still have good primary care, but that you will work in conjunction with them. There is evidence-based guidelines developed by the NIH that I would consult. We won't go over those now, but consult if you are ever managing a child with sickle cell anemia. And as I said, they will be in need of good primary care services. Also, to help manage the patient with sickle cell, staying hydrated is very important. Dehydration decreases the volume of the blood down, so those sickled cells can clump together more and can cause more of pain crisis. It's important to work with the patient and the family on illness prevention and pain management when there is a crisis. Labs that you'll perform will be a CBC and a retic count every few months. It's important to have the immunizations up to date, including the pneumococcal 13 vaccine. With these kids, bacterial infections can be the leading cause of death in young children with sickle cell, so prophylactic penicillin V is initiated by 2 months of age. At 3 years old, you'll increase the dose to 250 milligrams orally twice a day and continue at least till their 5th birthday. But all of this will be specified out in the guidelines. You'll give folic acid supplementation. You want to do aggressive treatment for infections, and also treat any coexisting problems that may be associated with hypoxia, because we don't want them to undergo hypoxia. And then hydroxyurea is used for severe sickle cell. It is helpful in reducing the number of painful crises and incidences of acute chest syndrome, which is one of the leading causes of death in adolescents with sickle cell crisis. And so it's important to also to do a stroke prevention screening for any major intracranial vessels and complete this by Doppler. And this evaluation is done usually between 2 and 16 years old. With these kids, often there is need for emergency admissions or referrals, and so some things to look out for are fevers greater than 101, if they have pneumonia, chest pain, or any other pulmonary symptoms, if they're experiencing a sequestration crisis. So you would know that if they had a decreased hemoglobin or hematocrit but were having splenomegalia, if there was an aplastic crisis, if they had a decreased hematocrit and retic count, if they're having severe pain crises, unusual headaches or visual disturbances, priapism, bone pain, leg ulcers, if they were pregnant or on contraception. Some complications that can be seen is a functional asplenia, which is your greatest concern in a febrile illness. This means that the spleen is not functioning as it should. You can have a pneumococcal sepsis, and so it's important to work up the fever if you're seeing poor feeding, irritability, lethargy. With hemolysis, you may see anemia, jaundice, cholelithiasis, and especially delayed growth and puberty if going on long term. And then also there's vaso-occlusive issues and ischemia if there's been an acute or chronic injury to any organ that needs to be investigated. Patient and family education is important. There has to be a partnership with the family and the parents to provide good communication so you know what's going on with the child. Routine immunizations, prophylactic antibiotics, genetic counseling, support groups to help support family and parents, educating adolescents with the trait possibility of hematopoietic stem cell transplant and gene therapy. So, needless to say, these patients are very complex and definitely need to manage this with a hematologist and possibly even your doctor that you are associated with to bounce ideas off of. Let's talk a little bit about hereditary spherocytosis. It's a hemolytic anemia that's characterized by a deficiency or abnormality of the red cell membrane protein spectrum, which reduces the RBC surface area. So instead of the RBC taking a round shape, it's taking more spherical shape, and these cells can be sequestered and then prematurely destroyed in the spleen. In mild case, it can be mild to a chronic hemolysis to then more severe transfusion-dependent anemia. It occurs in 1 in 5,000 people, mostly of Northern European ancestry. Because of this sequestration and lysis of the red cells, you're going to see jaundice in the newborn period. And it may be difficult to differentiate this from elevated bilirubin. After about 2 years of age, you may begin to note splenomegaly. These patients will also have chronic fatigue and may be noted to have abdominal pain. Diagnostic test that you would do would be to assess for chronic anemia. You're going to do a CBC, and you may note that the hemoglobin may be anywhere from 6 to 10. Reticulocyte counts may be anywhere from 5 to 20, and on a peripheral smear, a small percentage of the RBCs will be spherical and smaller than normal, and then the cells will lack a central pallor, and they'll be and some will be of their normal biconcave disc shape. You will notice some osmotic fragility in the cells, and then there are some tests out there to assess for prenatal or carrier testing, and those have been shown to have limited availability. So management of these kids, if frequent transfusions are needed, then splenectomy may be ordered. It's important to have their pneumococcal and meningococcal vaccines prior to splenectomy, and then they will be on prophylactic penicillin therapy after the splenectomy. Some complications that can arise are aplastic crises, which include fever, fatigue, abdominal pain, and jaundice. And those can be caused by the parvovirus and other viral infections that can have more serious complications during childhood. Any infection should be vigorously treated, especially post-splenectomy. And if you have a child who has a temp greater than 101.5 without an obvious source of infection, they should be hospitalized and treated with IV antibiotics until blood cultures are proven negative. Gallstone formation can occur as a result of the chronic hemolysis, and so ultrasounds may need to be completed annually before splenectomy and for any increased abdominal symptoms. Glucose 6-phosphate dehydrogenase deficiency, also known as G6PD, is a form of hemolytic anemia that's caused by a medication. Symptoms are associated with infections exposed to certain oxidant metabolites of drugs. It's important to get a clinical history on these folks, see if they've had a recent infection, see what medicines they've been on, aspirin, the sulfonamides, antimalarials, anti-helminetics, some of the quinolones, favabeans. On your physical exam, you're going to notice paleness. You may see jaundice if there's been chronic hemolysis. There may be lethargy, irritability, headache, red or dark urine after drug ingestion. Tests that you'll be performing are a dye reduction test. A G6PD screening is available in few states. Management, there's no specific treatment other than supportive care, so you'll be checking labs frequently and, if necessary, giving blood transfusions. And it's important that the patient and family are educated to avoid any offending foods and any drugs that might precipitate this again. Okay, this is the end of this section. We'll get started on platelets in the next video. Thanks.